Hi, Jackie. You can go whenever you're ready.
Okay. Just put the chat up. Good morning. Thanks so much for joining Case Reviews for October. As always, this information is privileged. It should not be shared with anybody else outside of this. Hold on, I'm trying to do the audio on my cell phone, or the case on my cell phone, audio off. Okay, but I'm getting feedback. Anyways, this information is protected under HIPAA and it should not be distributed outside of this lecture or copied in any way. So moving on to the first case. This is a case of a 56-year-old. EMS got called on shortness of breath, possibly asthma, and as they were en route, they were notified that there was bystander CPR initiated. The PPE usage documented included a surgical mask, gloves, and eye protection. At 10 minutes, which are the first set of vital signs recorded in the electronic medical record, showed that the patient's SAT was 65%, blood glucose of 157, and his estimated weight was 100 kilos. There was nothing recorded for heart rate, blood pressure, respiratory rate, although EMS was resuscitating him using ACLS and CPR. So for primary survey, the patient was found to be unresponsive. They noted that his airway appeared obstructed due to what appeared as edema affecting his tongue, and that he, because of this, appeared to be in respiratory distress and potentially apneic as well. They noted that his skin was pink, warm, and dry, but he was pulseless. And his past medical history provided was that he has a history of COPD, acid reflux, and anxiety. Additional information provided from Dr. Whitwer's review is that this patient had woken his wife up, had told her that he had bit his tongue and he couldn't breathe. She witnessed him collapse and she initiated bystander CPR for approximately 4 minutes prior to EMS arrival. So moving forward, I have it as document as 11:26, so this might be 11:26 in the morning. I'm not sure. But anyways, prior to transport agency's arrival, an intubation was attempted, had failed as this was deemed to be esophageal intubation, and that they noted the airway was obscured secondary to significant edema. So this kind of gives you an idea. This is not of the patient, but the way that they document was that the tongue was quite swollen and the anatomy of the larynx was also distorted as well. So at 2 minutes, cardiac arrest was confirmed, Lucas was applied, CPR was resumed. At 4 minutes, the patient had an IV placed and he was given 500 mLs of IV fluids throughout his encounter. At 6 minutes, his first milligram of epi was provided, and it's documented that the patient's initial rhythm was asystole. Later on, each time that he did arrest. An IO was placed in addition to the administration of epi, and then the decision per the narrative of the chart was that definitive airway attempts were made, again, due to concern that his primary reason for arresting was from respiratory obstruction. So video laryngoscopy was attempted, also was unsuccessful for the same reasons documented previously. At 10 minutes, those are the vital signs I had mentioned, where he was hypoxic at 65%, blood glucose 157, and he received a 2nd milligram of epi. At 12 minutes, his end-tidal CO2 was obtained. It was noted to be 59, and a 3rd airway attempt was made with direct laryngoscopy, which was ultimately successful. At 14 minutes, he received another milligram of epi, and at 16 minutes, ROSC was achieved. He had a full set of vital signs obtained, noted to be not tachycardic despite the multiple doses of epi. Blood pressures were soft at 94/50, bagged at 14, GCS of 3, and a 12 lead was obtained. Unfortunately, I don't believe that it was uploaded into the electronic medical record, so I can't show you a 12 lead on him. And because of his pressures being soft and presuming that he will likely become more unstable, he was started on an epi drip. And transport was initiated 29 minutes. While he was being transported, he went back into cardiac arrest, asystole, 2 more times. He received a milligram of epi. His epi drip was maintained. He received another milligram of epi at 47 minutes, and ROSC was achieved at 52 minutes. Vital signs at that time: heart rate of 120, blood pressure of 90/43, respiratory rate bagged at 12, GCS of 3, and end tidal of 47. He arrived to the hospital at 53 minutes. So this is, I don't know if Dr. Whitwer's on this call. Let me double check. Okay, perfect. This is your case that you reviewed, so I basically put in what your feedback was, so feel free to, or do you want to do the discussion?
No, it's fine.
Okay, so good that was documented was, or good that was reviewed was really aggressive airway early management as opposed to waiting until ROSC was achieved. And then areas for improvement: with multiple failed attempts and difficulty with visualization of the anatomy due to his edema, you can consider cricothyrotomy earlier. And then time to IV placement. And given that he's a respiratory arrest, bicarb may have been more beneficial earlier, or at least at some point during his arrest. And don't forget that we don't know why he has this edema of his tongue and his larynx, and that we may want to be considering, or we should be considering, potential anaphylaxis. So anaphylaxis management, including Benadryl, which he was receiving epi, and potentially Solumedrol.
So, did we have a list of his medications?
So I know that you had put additional information in there, and I'm not sure if that came from the ED or the hospital, but they had only documented COPD, GERD, and anxiety, and they didn't document hypertension, nor did they document any antihypertensives. So I'm not sure if that came from the fire chart or if it came from the hospital encounter, because I know you had said that he was indeed on lisinopril and that he was recently started on Lexapro.
Yep.
I would, and I would just say, if he's getting epinephrine, he's being treated for anaphylaxis, Benadryl is just a distraction. And I mean, this is incredible airway management, very well done. But I agree, if you're in a can't intubate, can't ventilate situation, start making preparations for the cric. Remember, in cardiac arrest, cric is slightly technically easier because it's going to be less bloody. But just start preparing yourself, start identifying the landmarks, and you can have someone working from above while you prepare to go from below.
Good points.
Sort of a two-pronged approach.
All right, so moving to his follow-up. So in the emergency room, he rearrested. He was given additional doses of epi. ROSC was achieved. He had pretty profound hypotension, requiring 3 pressors to stabilize him. He was treated with steroids, Benadryl, famotidine, bicarb for his acidosis, and he was transferred to the ICU. During his hospitalization, he underwent core-targeted temperature management. On hospital day 2, this was completed, but they noted that he was posturing and his pupils are asymmetric. He went in for an MRI brain, and it was pretty devastating anoxic brain injury noted. By hospital day 3, they did an EEG looking for brain activity, which there was none, and so family decided to make him comfort measures, and he passed away. So super tough case. Really amazing work that intubation was possible without surgical. So I thought this was a good opportunity to talk a little bit about angioedema, and not just what we might think of like anaphylaxis, but recognizing it's difficult to determine outside of anaphylaxis in these cases. So angioedema is going to be non-pitting edema affecting the face, the lips, the tongue, the larynx, and potentially even the intestines and the neck as well. So the classification is between acquired and hereditary. Acquired can include allergic reaction related, non-allergic reaction related, NSAID related, idiopathic, and additionally complement mediated secondary to acquired deficiency. Lots of potential acquired possibilities. But I think that the biggest ones that we think about is that is this anaphylaxis or reaction to some kind of medication that they're taking. And then hereditary is going to be when the patient has a inherited or hereditary, which is autosomal dominant C1 inhibitor deficiency. So the pathophysiology between the two, so acquired is acquired can be histamine and non-histamine mediated, but the bradykinin mediated is mostly associated with hereditary. So for histamine related, it's the most common one that we're going to present or we'll see in pre-hospital and hospital settings. It's secondary to mast cell release in that it also activates the basophils. And then the bradykinin mediated, which is what this picture is supposed to be depicting, is that with the C1 inhibitor deficiency that they are born with, when they are deficient with C1 inhibitors, so these, I don't know if you can see this too well, C1-INH over here, here, and here. So it leads to activation of the contact system, which causes uncontrolled production of I believe the spelling or the pronunciation is kallikrein, which then goes on to lead to more breakdown or proteolysis of the bradykinins. So when that occurs, there's increased amounts of edema and increased amounts of vascular permeability secondary to the bradykinin. So the management, since we're on this picture already, for bradykinin mediated is to affect each area of this pathway. So the first one would be to give them a C1 inhibitor concentrate that's created or comes in plasma administration. And then the kallikrein inhibitor is going to be this escalotide. Hopefully you guys aren't paying attention too much to my pronunciation. And then the other potential agent to treat the bradykinin mediated pathway is the incapitant, which is the receptor antagonist for the bradykinin. But the more easy for me.
Jackie, the take home from this is hospital treatment, not EMS treatment.
No, the bradykinin is, but what I'm talking about is that the more common one is the histamine mediated. So the more common one is the one that we're going to be treating as potentially as anaphylaxis, and that would be antihistamines, corticosteroids, epinephrine, and then stopping whatever the offending agent is, if that's a medication related or if that's a contact with some type of environmental factor. And then obviously in both of these cases of the histamine or bradykinin is establishment of an airway early before it gets worse. So the only reason why I talked about bradykinin first is because I was already on the picture, but it's the least common and obviously the least possible for us to manage in the pre-hospital setting. But it's difficult to determine this unless they already have an established history of hereditary mediated angioedema.
And some patients with hereditary angioedema will have a pre-plan. It's a very small number of them that have the agent at home. It's more common that they've already identified the hospital that has their agent and they know where to go. So that's the one other thing to history to gather in the pre-hospital setting.
Yeah, so
Right.
exactly. And because it's difficult unless they have an established history, the management often is to treat it as potentially anaphylaxis. It's just it won't respond. So going over our protocols for allergic and anaphylaxis, we recently covered this a couple of months ago. But mild reaction will be managed with Benadryl. Severe reactions as dyspnea, wheezing, laryngospasms, angioedema, or shock would be treated with epi in the form of sub-Q or auto-injector, as well as a consideration of initiating an epi infusion, giving them IV fluids, treating them with Benadryl, bronchodilators, and steroids. And then if they're refractory to these agents, starting them on norepi strep. Yeah.
Jackie, not sub-Q, IM.
Yeah, sorry. I am an injection. Thank you. And then as for pediatrics, I try to put these up here since we oftentimes don't always talk about our pediatric form of things. So bringing up that the comparison in pediatrics with allergic and anaphylaxis, mild reaction similar to this as adults. So you're going to be giving them IV fluids, placing them on the monitor. I would say that you would be considering placing an adult patient on the monitor as well. And then, sorry? Somebody asking a question? All right. And then also Benadryl, same dosing as 1 mg per kg as the adult with a max of 25 compared to a max of 50 for adult patients. And then moving towards the severe reactions, similar to adults with the consideration of all of the same agents, just reduced dosing in concentration. Or no, just dosing. Any other questions or concerns? Great, then we're going to move on to case 2. Case 2 is of a 78-year-old female. EMS was contacted for a possible sick case. She was complaining of feeling kind of clammy. PPE usage is mask, gloves, and eye protection. And documentation of vital signs were obtained prior to transport agency's arrival. So noted to have a heart rate of 92, blood pressure of 121/59. Respiratory rate was not taken, GCS of 15, stats of 96%, and she was documented to be approximately 75 kilos. They found her to be awake, her airway was open and protecting, her skin was pink, warm, and clammy, and there was no signs of active bleeding. The previous past medical history included osteoporosis, bronchitis, and heart failure. They found her sitting in a chair in her home. She said that she had 7 days of back pain. She felt constipated. She reported her last bowel movement was 4 days prior. And she also had some left upper quadrant pain that radiated to her chest, and she felt like she wasn't very hungry. In addition, she states that she had dark stools that she suspected was from a GI bleed, and that she felt short of breath earlier that day, but not at the time of EMS arrival. So these vital signs, as I mentioned from the previous slide, at 6 minutes, they got a blood glucose and they placed an IV. At 7 minutes, a second set of vital signs noted to be afebrile, not tachycardic, normotensive, respiratory rate now 22, but stats are still high at 97%. And at 11 minutes, the first 12 lead was obtained. So looking at this EKG, obviously she's not in her 30s or 40s. She's an older woman. So we don't know what her past EKGs have looked like, but presume that she's had previous EKGs. But looking at this looks kind of ugly. You look at these deep, what looks like ST segments, and you might think initially, oh, she's got a bundle branch block. You can look and see that her QRS is actually 0.08, so this is not a bundle branch block, but otherwise, now you're looking at a narrow complex. You see these ST segments that are depressed in 2, 3, and AVF, as well as in her V2, V3, V4, and V5, and potentially even V6. So given the fact that she has some cardiac pulmonary complaints, her EKG has these ST depressions that could represent ischemia. And if you look at this further, you're looking and you see, was there any reciprocal changes? And it looks like she has ST elevation and AVR. Ideally, having a previous 12 lead would be helpful to compare if this is old or new for her. But one of the things that we do have both in the hospital and the pre-hospital setting is serial EKGs. At 16 minutes, transport was initiated. At 22 minutes, another set of vital signs were obtained. Similar to previous, still not tachycardic, not hypotensive, and not hypoxic. Another 12 lead was obtained at 24 minutes, 13 minutes from the previous one here. Kind of a artifact, but similar in appearance just by grossly looking at it. But you have an old EKG that you had gotten 12, 13 minutes earlier. So comparing the two, now you're looking at these ST segments don't look as pronounced. Depression doesn't look as pronounced as the first one, especially in the precordial anteroseptal leads. You still have ST elevation. So in this setting, this is dynamic changes, suspicious that this is an acute process, even if her history isn't necessarily slam dunk easy for potential cardiac. Another set of vital signs were obtained, similar to the previous 4, and she arrived to the hospital at 34 minutes. So in reviewing this case, I thought that this crew did a great job of getting serial 12 leads, serial vital signs. They did not give this patient aspirin because of the fact that she reported potentially GI bleed and that they got IV access. Where we could do better in the future is that the first 12 lead was 11 minutes prior or after patient contact for the transporting agency, and potentially even longer, depending on how long the first agency arrived. And that there were some EKG abnormalities, and there were changes in subsequent EKGs. So this patient came back code 1 to the hospital. Maybe this would be a patient that should be coming back with potentially unstable angina or ischemia as a code 3. And then if the crews were concerned about this patient's EKG, they can contact online medical control to have them look over this EKG, especially if they can send it into Pulsera. But even if they thought that this patient's EKG was concerning for ischemia, as we'll talk about here in the next subsequent slides, this EKG doesn't meet our criteria for STEMI activation. Does anybody in the audience want to put in the chat what they thought about the EKG? Or how about I pick somebody, unless somebody volunteers? I'll find it. Hold on. I'm sure anybody who would like to.
Jackie, do you want me to do this, or are you looking for
No,
it?
I don't want
Okay.
you to do this because.
Okay.
Thank you, though. I appreciate it. How about Fire Station 43 or 42? Because I assume there's not one person there, or 63, that anybody from these stations can put in what they think about this EKG.
Hey, Jackie, Station 42 just had a very cogent answer in the chat, if you want to check that out.
Yeah. Great. But B2, well, I would say that I agree that there is ST depression in V2, V3, V4, V5. With that portion of it, it's concerning for ischemia. And station, what I don't know, agrees with 42. Yeah, and then AVR is the other area that I would want you guys to draw your attention to. So this case came up because the hospital recognized a delay in notification, not just on the pre-hospital side. So that's what I'm going to present in the next few slides. So the charge nurse put in that the EMS notification was that this patient had back pain for 7 days, constipated, and was having difficulty for eating. So that was the triage chief complaint. This patient went out to triage, At 33 minutes, the patient was seen by the triage nurse, and at that point, she stated to the triage nurse that she had chest pain, worse with eating, radiates to her back, she was short of breath, and that she last had a rectal bleed 4 days previously. At 38 minutes, the triage doc saw her, put in labs and an EKG. At 82 minutes, her labs came back with her troponin being elevated greater than 4,000. At 87 minutes, the patient was roomed into the emergency room. At 103 minutes, her first 12 lead was obtained, which is this, which is very similar to what EMS had, except for I would say that the ST depression seems to be worse. So again, she's got these ST depressions in the inferior antral septal leads, and she has this ST elevation AVR. The cardiology was consulted, and she went to the cath lab at 135 minutes after she arrived. In the cath lab, she was noted to have multivessel disease affecting her LAD, her left circumflex, and her right coronary artery. She was placed on an intra-aortic balloon pump due to systolic heart failure. And once her, I believe yesterday, she would have gotten her CABG. And they were going to replace her mitral valve regurgitation. They were going to replace her valve for her mitral valve regurgitation. So this case, like I mentioned, was brought up as a delay in identifying a STEMI. So I want to talk a little bit about posterior MIs. One, how to identify them. Two, how they play into our notification. So posterior MIs comprises approximately 20% of STEMIs that involve inferior or lateral portions. And they're significant because that means that there's significant enough muscle damage that it's not just involving the inferior or the lateral, but also the posterior. So it puts them at high risk for arrhythmias and sudden cardiac arrest. Only 11% of MIs are posterior only. And how we identify these patients is that we recognize that there's ST depression, usually in the anteroseptal leads V1 through V3. This patient, I would say, had anteroseptal and lateral lead involvement. And then you're also looking for tall, broad R waves. So I don't think this goes now. Tall, broad R waves, Q is your negative deflection, R is going to be your upward deflection, so greater than 30 milliseconds, upright T waves, and dominant R waves in V2. So if you identify this pattern, if you identify ST depression, especially in your anteroseptal leads, if you look over at your AVR looking for ST elevation, this would be highly worrisome for a posterior MI. And if you identify that, you can confirm what you're looking at by checking right-sided leads, V7, V8, and V9. So these are going to be on the horizontal plane at V6. I'm going to move that down. So the V7 should be placed at the left posterior axillary line. V8 should be placed at the inferior aspect of the scapula spine, and V9 should be just left of the paraspinal. And then why do you have the EKG changes that you see with posterior MIs on your original 12 lead placement? And that's because normally the anteroseptal leads are going to be looking from the anterior precordium towards the internal posterior aspect of the myocardium. So the injury pattern that you would expect to see with our typical STEMIs are going to be inverted. So when you see ST elevation, you'll see ST depression in these patients. When you see Q waves suspicious for myocardial tissue death, that's actually going to look like R waves for us. And then T wave inversion that we normally see for ischemia is going to be upright T waves in these patients that are having precordial posterior involvement. So just an example, the picture previously was from this patient's case, but this is a different patient. So again, looking at this 12 lead EKG, these look pretty narrow, complex. You've got these ST segment depression in. So kind of starting from left to right, looks like you have ST elevation, in one, but not in AVL. You have this, what appears to be ST elevation 2, 3 AVF. You have ST depression in V3, V1, V2, V3, less so in V4. And then with this information, you kind of look over at AVR, you don't see ST elevation here. If you put on your right-sided leads, I'm sorry, your precordial, your posterior leads, you're going to see that this ST depression now is actually ST elevation, much more aware to evaluate for for an ischemic injury. And then for us, our protocols for STEMIs, actually, did I not have the other one? No. So anyways, I'm just going to talk about ACS and then I'll talk about STEMI here in a second. So universal precautions, we need a pulse ox on these patients. We should not be placing them on oxygen unless their SATs are below 94%. Getting a 12 lead within the first 10 minutes of patient arrival, giving them aspirin unless it's contraindicated, they're actively bleeding or they have an allergy to aspirin. If they're hypotensive, we're not going to be giving nitroglycerin. But if their blood pressures are above 110, we can. And then potentially administration of fentanyl, 1 mic per kg, no more than 100 mics per dose. And then for STEMIs, this is going to be, let me pull up our protocol real quick, but for STEMIs, ST elevation, I believe it's 1 millimeter and you have reciprocal changes, but AVR does not count for these patients. So if you do believe that your patient is having a posterior MI, and you're not seeing elevation in the other leads like lateral or inferior, we ask that you notify the hospital that you're coming in code 3, but these ones are not activated immediately as a STEMI until the physician evaluates them and discusses it with cardiology.
Jackie?
Yes.
I will just gently point out that this was part of the lecture in, I believe it was either July or August, and I did about a 4-slide thing on ST elevation in AVR, and about 10% only of those patients will actually turn out to have an MI. Usually it's related to something else such as sepsis, but the characteristic that they should be worried about, and that what we had talked about, notifying the hospital that this is a significant ACS patient, is that ST elevation in AVR with almost universal ST depression in every other lead is a red flag, and that needs to be brought to the attention of the physicians, but not to call it a STEMI at that point.
Yes. And I would say that, if you're finding that you're having a difficult time relating to the hospital that you're concerned about angina and ischemia, if you do end up calling it a STEMI, the ER doc is to ultimately determine if it gets a cath lab activation. But ideally, we call it what it is and what our worries are about this patient instead of calling it a STEMI activation.
Exactly.
But that just that pattern, the ST elevation in AVR with diffuse depression everywhere else, is either left main disease, multivessel disease, or in some cases it'll be like some mild multivessel disease plus anemia. So it's always concerning, and then especially the dynamic changes are always concerning. So from my perspective, the key thing is just to get this EKG in front of a doc.
Right.
Yeah, and so in reviewing this case for the hospital, I thought that this was a particularly difficult case for the crew, for any crew. I mean, this patient talks about a week-long worth of symptoms, a multitude of different organ systems that she's complaining about, and it would really have, because of the fact that you're looking at an EKG that with first glance you could say, oh, it's just a bundle branch block, and you weren't really paying attention to this 12 lead very closely. and not recognizing the changes from her previous EKG, because you'd have to like pull up and compare side by side. This is a patient that I think that would be challenging for a lot of for anybody, and that it's unfortunate that this patient had a delay in identification, but it reminds us about the importance of what we do, in that not only when we assess a patient and we determine them to be okay, that can be falsely lulling to the hospital as well, and that they continue suit with that. All right, if there's no other discussion, let's look at the chat, then we'll move. And thanks for the participation from Station 42 and the other station that responded. So this is a 75-year-old female. EMS got this as a sick case. PPE usage included mask, gloves, and eye protection. Prior to arrival, her vital signs were obtained by first responding agency. Heart rate noted to be 133, blood pressure 121/92, respiratory rate of 36, SATs of 84%. Her blood glucose came back as high, and her weight was documented as 143 kilos. On primary survey, she was only responsive to painful stimuli. Her airway was open, but they felt not protecting, and that her skin was pink, warm, and dry with a strong regular pulse. Her past medical history included anemia, type 2 diabetes, obesity, hyperlipidemia, and heart failure. And according to the documentation regarding the history leading up to her presentation, is that she ran out of her insulin a few days earlier. So the vital signs, as I mentioned prior to arrival, initial vital signs on transport agency arrival is that her heart rate was 94. She was placed on 8 liters nasal cannula. They did a physical exam noting that her pupils were equal round reactive, and that they noted that she had some decubitus ulcers on her back, and they had described it as severe. At 8 minutes, an IO was placed, and she was administered 200 mLs during her encounter. At 10 minutes, another set of vital signs were obtained. Heart rate 88, blood pressure 144/112, respiratory rate of 42, GCS of 5, and end tidal CO2 now 11. At 11 minutes, transport was initiated. And at 17 minutes, another set of vital signs were obtained. Heart rate of 132, blood pressure 124/82, respiratory rate of 40, GCS now 4, end tidal still the same at 11. It's documented in the narrative of the electronic medical record that online medical control was contacted, and I believe this was contacted of Legacy Salmon Creek, in that the feedback or the advice from online medical control was do not intubate this patient if at all possible. And from the way that it was documented, it said that it could lead to her cardiac arresting. And I believe this is feedback that we can get from Dr. Mock. So good, or at least this is the feedback that I had pulled from Dr. Mock. So use of end tidal CO2, expedited transport, neurological exam, and IO placement. And then as for room for improvement, consideration of more IV fluid administration than 200 mLs given the 36 minutes of patient contact, second line if possible, and then 12 lead EKG. In the emergency room, her pH was noted to be 7.13. Normal values are between 7.35 and 7.45. Her bicarb was 19. Normal values should be between 22 and 29. Her glucose was 536. She was noted to be seizing upon ED arrival. Ativan was administered to her to terminate any seizures, and that during her resuscitation, she was also intubated for airway protection, and that they agree with the decision not to intubate in the field, good handling of this difficult situation. And then as for the hospital course, she was admitted to the ICU. She was extubated on hospital day 6. Her DKA had corrected, and that she was also noted to have pneumonia and emphysematous cystitis. I tried to look her up after this review, as this was all in the setting that she was still admitted. I'm not sure if she's still admitted or not. I don't know if Dr. Mock knows. And I don't
believe she was discharged to a skilled nursing facility.
Okay. So this case was brought as a suggestion, as a kind of a reinforcement of what we talked about last month, where you want to make sure you resuscitate before you intubate, especially when you're dealing with any type of metabolic acidosis. As we talked about last month, hypotension, hypoxemia, and metabolic acidosis can lead to cardiac arrest in these patients. So it's not just prior to intubating, but it'll be continued after intubation to deal with hypotension, hypoxemia, and acidosis. Agree that in these severe metabolic acidotic patients, that intubation should be only pursued as you're forced to do so, as this is a potential airway impairment, or if you are dealing with the fact that this patient's airway will become not protected at all. So if you're going to move towards intubation, you want to make sure that you resuscitate as best as you can before. If that's going to be high flow oxygen, prep your equipment, plan for how you're going to ventilate this patient prior to intubating, so that you have a plan that's determined by your entire operation. And that in these patients, we talked about the severe dehydration, as well as the potential for acute kidney injury and hyperkalemia. So really avoiding succinylcholine in these patients, if at all possible. Having the most experienced provider that, or whatever that would take, to make sure that your first pass success is 100%. And then at least ventilating them at a rate of 30 when you first intubate and start ventilating the patient, and then preparing for any kind of cardiac arrhythmias, especially as these patients are prone to deteriorate. Any other questions, thoughts, additional information before?
I would say if you were forced to intubate someone in this situation, you, as close as possible, you tried to match what they were breathing before. So like someone in DKA or someone with an aspirin overdose that has a significant metabolic acidosis. So noting their respiratory rate, you can try to titrate to the same end-tidal CO2, but you're going to have to breathe for them fairly rapidly to keep up with their demand. And but what really kills them is that period of apnea where the acidosis gets worse before you start bagging them again.
Absolutely. And like we talked about last month, we're not looking to bag them for an ideal end-tidal CO2.
Now, I just want to clear up one thing. You said that they contacted medical control.
Yes,
Correct.
that's what's
Okay.
documented in the narrative.
Okay, so that has to be medical control at Peace Health.
I'm not sure. It seemed like it wasn't at Peace Health.
So they don't
But-
contact,
But
they don't contact medical control anyplace else. So it's possible they were told that as they were transporting to Legacy, that they might have had a conversation, but they wouldn't contact medical control anyplace except Peace Health.
It doesn't say the physician at Peace Health, so it seemed like maybe that they were notifying the hospital that they were coming.
Okay.
So I can't speak to that it was clearly Peace Health unless the crew is available on this call or can later feed back to us if they contacted Peace Health or Legacy Salmon Creek.
No, the documentation says Dr. Burke, who's one of my partners at Salmon Creek, said, if you intubate this patient, you'll kill her. No, I don't know if that was, chimed in on the HERE report or whether they were calling, asking for direction. But I agree with Dr. Whitwer's point that if you're calling for medical direction, call Peace Health.
Thank you for those points. So going through our protocols in regarding altered mental status where hyperglycemia and hypoglycemia present in our protocols. So in regards to hyperglycemia, we advise to check blood glucose if it's reading high or well above normal, glucose greater than 250, and there's signs of dehydration, polydipsia, polyuria, vomiting, GI symptoms, altered mental status, to start with a 1 liter bolus IV fluids and reassess if additional IV fluids are needed. All right, one more case. This is the case of a 42-year-old male. EMS was contacted for heart problems and breathing abnormalities. PPE usage included HEPA and surgical mask, as well as gloves and eye protection. At 5 minutes after patient contact, vital signs were obtained. Heart rate 135, blood pressure 142/103, respiratory rate of 14, GCS of 15, SATs of 96%, and the patient was 120 kilos. They noted that his airway, or that he was awake and oriented. His airway was open, he was protecting, and his skin was pink, warm, and dry. Presumably tachycardic and irregular was his pulse. Past medical history included kidney disease, AFib, cardiac disease, and a seizure disorder. The history provided by the patient was that he was experiencing heartburn type pain. His AFib, per the documentation, was out of whack, and that he had a similar presentation 2 weeks prior. He was also complaining of some nausea, and he reported that he was a former meth user. So as mentioned earlier, 5-minute vital sign, 9 minutes, an IV was established, and he was given 300 mLs of IV fluids throughout the resuscitation. First 12 lead was obtained at 9 minutes. So narrow complex, a bit of artifact, but appears to be regular as far as we can tell. No obvious ST elevation, maybe some ST depression or T wave inversion in lead 3, but overall pretty hard to read because of the lack of baseline and then artifact causing this to not be a very clear EKG. The first 2 lines of the narrative documentation talks about the service dog, which didn't seem to necessarily need to be in there, but nonetheless it was. At 12 minutes, he was given 100 micrograms of fentanyl because he reported pain 8 out of 10. Prior to giving the fentanyl, though, the documentation is that he reported he was a former meth user and that the team asked if he had problems with pain meds. And then after he received his first dose of fentanyl, they felt that his pain, or he reported that his pain barely moved down. 17 minutes after patient contact, transport was initiated. Another set of vital signs were obtained. He's still tachycardic at 134, blood pressure 129/86, respiratory rate of 12, and a GCS of 15, SATs of 96%. Then they reassessed his pain score, which he said was a 7 out of 10, and he was administered his second round of 100 microgram fentanyl after 7 minutes. Then he became unresponsive and blue. They gave him some Zofran, they gave him some oxygen, and they gave him at 24 minutes 2 milligrams of Narcan. They document under procedures an iGel BVM, so I have to believe that an iGel was placed. And then they said that he was given another 0.5 milligram of Narcan at 29 minutes. He woke up in a fast rhythm after getting the second dose, which they gave the second dose stating that they wanted to get him back sooner than wait. And then 33 minutes, he's noted to have a heart rate of 147, blood pressure 154/98, respiratory rate at 27, GCS of 15, and end-tidal CO2 of 24. It's documented that they recommended cardioverting this patient. They got another 12 lead here. A little less wavy on the baseline, but still quite a bit of artifact. Still appears to be narrow complex, and it appears to be regular. No ST elevation noted on my review of this. So the patient refused cardioversion or adenosine, and they got another set of vital signs in another 12 lead. And ultimately, the patient had disclosed that he had gotten Narcan last time, assuming it was a similar kind of presentation, I guess. And then he arrived to the hospital at 45 minutes. So the good here is that the first 12 lead was within 10 minutes of patient contact, especially when we're dealing with potential cardiac, either abnormal heart rate or suspected arrhythmia or chest pain. Line was placed, a pulse ox was administered or placed as well, in that an end-tidal CO2 was documented. End-tidal CO2 was documented after receiving a couple doses of fentanyl and a couple doses of Narcan. And that a pain scale was recorded, and that serial 12 lead EKGs were obtained. Areas for improvement, I would say if we ever find ourselves in a situation that we gave a medication that led them to become in respiratory distress or arrest, that ideally we could bag them before placing an iGel, especially if we think it is transient, something that is not going to be long-term. But that's just my take. If an iGel is the best way to bag in the back of an ambulance for the duration of Narcan administration, I'll leave that to the NPD group to discuss further. Documentation, I felt that there was some extraneous information in here, which I kind of alluded to in the treatment slides, in that it was more of a defensive report than it was of speaking factual. And then pain management, I don't think this patient necessarily warranted all of the narcotic pain medications that he received, especially because he appeared to have two processes going on at the same time. And potentially the first process, his AFib, his tachycardia with a history of AFib, could have been leading to some indigestion complaints and doesn't necessarily need narcotics for management. There may be better agents to do that. And then reminder of the indications for cardioversion. These would be unstable patients. These are patients that are hemodynamically unstable or that are altered or getting sicker before your eyes. So in the emergency room, cardiology was consulted. The patient had a similar EKG to what EMS had, but reviewing his old EKGs, they determined that this was most consistent with a flutter. He was started on a cardizem drip, and that a flutter or fib, they didn't know how long he was in it, so they decided that they were going to rate control, confirm that he doesn't have a thrombosis by doing an echo, and that he was indeed intoxicated. His alcohol level was 304. They did get a CAT scan of his chest looking for a PE, and they also got a CAT scan of his belly since he was complaining of some epigastric discomfort, which showed no PE and evidence of cirrhosis, likely from alcohol abuse. During his hospital course, they resumed him on the cardizem drip. He had a complicated stay because he went into severe alcohol withdrawal with metabolic encephalopathy, as well as hepatic encephalopathy. And he was cleared for discharge on hospital day 10. Any questions, thoughts before moving forward? It's okay, we can talk about it later too. So iatrogenic, just a reminder of this term, it's the result of a diagnostic or therapeutic procedure on a patient that leads to disease or adverse event. And then in this case, we're talking about fentanyl. I know that we recently had changed our protocol on fentanyl, but we've had an uptick of a couple cases now that have led to Narcan administration in the field. From what I could gather, and I think that this is reasonable to say, is that opioid-related iatrogenic adverse events are generally predictable and avoidable, but it's identifying who is at high risk for an adverse event from an opioid. So these are patients that can be anywhere from somnolent to hypoxic to respiratory arrest. I did find a study that talked about preventing iatrogenic overdoses. This was a study that came out in 2015, and this was a retrospective study looking at 2 academic emergency rooms in the New England area. They queried how many of their ED patients that received Narcan after receiving opioids. They found during their time period 73 ED patients that received Narcan after receiving opioids. And they thought that of those 73, 43 were due to med error. So they thought after reviewing their data that the contributing factors leading to having to give Narcan to their pain managed patients was that these are patients that had chronic health conditions, and that included altered mental status, dementia, as well as chronic pain, and anybody that already had prescriptions for benzos or opioids at home. They also recognized that there seemed to be a higher correlation to adverse events with opioid administration if there wasn't adjustment to the dosing if the patient was elderly or had impaired hepatic clearance or renal clearance, and that there seemed to be a higher propensity for opioid-related adverse events when multiple doses of medication, multiple narcotics were administered or multiple routes were administered, as well as patients that also had sedatives on board. So intoxication would be considered a sedative, but also any of our benzos and agents that would affect our patient's ability to ventilate in addition to administering opioids. So reviewing our pain management protocol, we want to know what their pain scale is. We want to treat and consider and treat their underlying cause of their pain. We want to consider our non-pharmacological agents that can help alleviate pain. So that could be positioning, that could be splinting, that could be coaching them to breathe through their pain, depending on obviously what the condition is that's leading them to have pain. Options that are available would include NSAIDs such as ketorolac, opioids, and ketamine. Less so nitrous oxide. I'm not sure if we have that in our to our disposal or if that's like a very limited case, but either way, those are your
Just North Country.
Okay, cool. I was gonna say I didn't think that, but anyways, so our Toradol really isn't an option for anybody that is outside the age range. So 2 to 64, they're pregnant, they're in trauma entry, or that they have they're on anticoagulants. So that probably is pretty limited for potentially there's a very small subset of patients that would get Toradol. In that if we're going to be administering opioids, we're not administering it for any chronic pain situation, ideally. In that remembering that our dosing is 1 mic per kg, IV, IO, IM for a max single dose of 100. We do have the intervals of every 3 to 5 minutes, no more than 300 micrograms, but I would advocate myself for if we're going to redose, maybe a smaller amount than the last dose, or that we really lean towards the 5 to 10 minute interval so that we try to avoid any iatrogenic unintended cases of opioid overdose requiring Narcan in the pre-hospital setting because of our actions. And then ketamine is an option, IV or IM, only after 2 doses of narcotics are being administered. So I'm not sure if that might have led to some of these cases in our change in our protocol, but either way, those are the pain management options in our system. As a reminder, fentanyl's onset's 2 to 3 minutes. It peaks at 3 to 5, and it lasts anywhere from 15 to 45 minutes. And we do, under our precautions for fentanyl, have a couple that would hit some of the points that was brought up on that study, where we recognize that that fentanyl can cause respiratory depression and it can be exacerbated by underlying medical problems or diseases. So be prepared by knowing where your Narcan is if you absolutely need it. In that our second precaution that we have is that if we administer it rapidly, it can lead to chest rigidity or muscle spasms. So the only way that might overcome that would be to overcome neuromuscular blockade. And then thirdly, that we should be administering it in a decreased dose in any of our elderly patients potentially because of the decreased ability to clear it. That's all I have for that case.
Okay, Jackie, can I weigh in on this? I think that I agree with you. I think that that we're going to move that out to 5 to 10 minutes. That'll give us a little bit more. Even though this case it was given at 7 minutes, so that's the second dose, but probably the doses should have been much less for someone who is clearly intoxicated as well. You can't. I cannot believe that they were not aware that someone with an alcohol of 0.30 was not was not obviously intoxicated and didn't smell like it. Now, the other thing is that I'm always of the opinion that I would rather give small amounts more times than give a large amount and worry about having to suck it out, because you can't do that. And also a reminder that we're not, it's not necessary to 100% relieve the pain that people have in the field. And then the last point is the mainstay of treatment of opioid overdose when they are in respiratory depression or even apnea is to start bag valving them with oxygen first and then give the Narcan.
I agree. So in summary, we presented cases of angioedema, posterior MI, metabolic acidosis, potentially needing airway protection or securement, and fentanyl hospital or pre-hospital administration of fentanyl with an unintended adverse outcome of apnea or respiratory arrest. So in summary, if you have an angioedema case, you should be considering possibility of anaphylaxis and treat accordingly. If you have difficulties in managing or securing the airway, you may need to consider crike. Recognizing what EKG findings would be concerning for posterior MI and how to confirm that by lead placement, and also noting that these patients likely have multivessel disease if there's more than one area involved, or if they truly are just seeing evidence of just a posterior MI. It's rare, but that would require intervention, and that we won't call these STEMIs, but we'll ask online medical control to be aware and ready for potential activation. And then resuscitating our patients, especially when they're in extreme metabolic acidosis, such as DKA, before and after intubation, ideally not intubating these patients if any way possible. Lastly, our opioids, considering controlling their pain, but not necessarily eliminating their pain. I believe that giving patients reasonable expectations of what your goals are would be helpful. In my practice, I ask patients what their pain is, and I tell them that, okay, your pain's a 7. My goal is if we can get it down to half of that. If it gets better than that, that's fantastic. But if we get down to half, I think that's a reasonable goal. And I think that setting those expectations are helpful even in the pre-hospital setting. And also, as Dr. Whitmer mentioned, you can always potentially give more. It's harder to remove, and you ideally don't want to be using any reversal agents in your management package. That's all I have.
Jackie, what is that last picture? I can't really see it well.
This one?
Yeah.
Narcan nasal injection.
Oh, it's a Narcan nasal squirt. Okay.
Well, thank you guys for your attention. Thank you for the discussion and involvement of everybody.
Thanks, Dr. Gadbois.
Thank you.
Thank you.